Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hey everyone, welcome back to Cardiovascular Matters. I'm here with our host and my mentor, Dr. Craig Walker from Houma, Louisiana. We're going to be circling back this week and really talking about something that happened a couple months ago. Dr. Walker, who founded Cardiovascular Institute of the South, has really spent his career highly focused on the areas of peripheral vascular disease and even more importantly, a critical ischemia. And a couple months ago, Dr. Walker and his group was awarded the Global Limb Salvage Award, and that was presented by Kim McNicholas, who is the CEO of the Way to My Heart Incorporated. And it's a very prestigious award that's given to groups that basically have spent their time and focus in medicine to basically prevent amputations. And today what I wanted to do is just spend a few minutes with Dr. Walker and kind of circle back and talk about kind of what that's meant, but also take a deeper dive to understand Dr. Walker's efforts with other physicians to train them so that, what was once unique down in Houma is now the standard of care around the United States. So, Dr. Walker?
Thank you, Terry. Obviously, this award was a vindication of a lot of the work throughout my life. Amputation is severely debilitating. It's really a tough procedure, and albeit it is needed many times to save a life, I think for ischemic disease, it has historically been performed far too often, particularly with many of the newer therapies that we have. Now, some of these newer therapies I was involved in helping to develop over the years. And the whole idea was that we should at least know someone's blood supply to the leg before considering amputation. Now, that sounds like a very basic step, and it is a very basic step. However, that was not being done all too often. In fact, more than half of all amputations secondary to diminished blood flow to the legs were performed without an angiogram or even any form of a vascular assessment ahead of time. That's simply, in my opinion, unacceptable. And so what we found was when we did angiography or we performed ultrasound ahead of time, often we found that these patients had very simple lesions to restore flow, and sometimes, of course, very tough lesions. Well, we worked to learn how to open the very tough lesions, and of course, the very simple lesions were very easy to treat. Now, it became very obvious to me, though, that we had a real shortage of doctors trained in vascular intervention. So I did something that was actually quite unique at that time. I set up a program to train physicians throughout the United States. 4 at a time, physicians would come with the technicians that they work in their labs, and I trained many of these. In fact, almost 2,000 came through 4 at a time from these sessions that we're doing, where we were performing many procedures a day, and these doctors could get a feel for the equipment and see how this worked.
Right.
And now many of these physicians are leaders throughout the world in peripheral vascular intervention. Now, I'm very proud of that accomplishment, but I'm happier about the fact that we are making a dent in how we're dealing with peripheral vascular disorders. But we still have a long ways to go. Still, in the United States of America, many amputations are being performed without a basic vascular assessment. That should not be the case in today's world, except in cases where it is life-saving, where someone's so septic or has infection that's so bad that one cannot wait. But often that is not the case. Often people say, well, there's nothing I could do in this case. And that's not good enough, I think, in our world today. So the award was really based, I think, on advocacy, on training, and the fact that we have performed tens of thousands of limb salvage cases. And of those, these were patients that were typically told their only option was an amputation. Far more than 90% of those were able to save those limbs. And I think that really means saving lives as well, because there's some statistics that people don't recognize. For the below the knee amputation at the best centers in the world, not the average center, but there's somewhere between a 5 to 8% 30-day mortality. They die. And for above the knee, somewhere between 8 and 12% 30-day mortality. Almost half of those patients in those groups are dead within 2 years. Many report a quality of life worse than lung cancer. And so clearly we have a mandate to try to do better. And many of our governmental agencies are starting to recognize that peripheral vascular disease, and in particular, critical limb ischemia, is a real health problem that needs appropriate attention. In fact, they've earmarked it for additional attention, and it needs this because the incidence of severe peripheral vascular disease is going up. It's going up because of the biggest risk factors, which are advanced age, and our population is aging, because of diabetes. And diabetes, as we've mentioned on some of our podcasts with our Americans getting obese, is on the rise. In fact, a tremendous increase in diabetes. And of course, it's related to cigarette smoking. So we can and must do better with these cases. And certainly in one of our podcasts, we talked about the many advancements. And even since our last podcast, so many new things are coming out. I really believe we will get to that point where in the future, amputations due to obstructed blood flow in the limbs will fall dramatically. It will be an uncommon event. But unfortunately, still in our world, it is far too common. And Kim McNicholas and our organization are dedicated to decreasing that numbers, to decreasing the numbers of amputation. And certainly I appreciate the effort because I've been working with this for more than 30 years, trying to improve outcomes, often when the tools that we had and the techniques known at the time were very poor. Nonetheless, I always thought it was worthwhile to save a limb when we could. These procedures took a lot more time. We were paid a lot less for them than we were for coronary procedures, but it was part of my mission. I thought it was something that was very important. One of the things I found, Terry, was that patients in whom we can save a limb are actually more thankful often than those in whom we save a life. And I think that's very important, but they all go together because I really think saving limbs means saving lives.
Yeah. One thing I wanted to also mention, and, again, I was a medical device rep for 30 years, and I've seen virtually every surgical procedure. And again, these are all very necessary at times, but, a lot of the techniques and approaches that you take and avoid bypass surgery and, the bypass wallet, there's certainly a place for it, and, people may have to have those, but if you can certainly avoid that and get that done through a needle stick and not invasively, talk about that. That's
it's a great point.
Like limb salvage,
It's a great point. Yeah, bypass requires a few things. It requires, number one, a patient who is capable of withstanding surgical stress because it's a big operation. And many of these people are old and frail to begin with. Next, it requires inflow, which means blood flow into a segment above this to where you're planning to start your graft. Well, usually we can achieve that. Next, it takes adequate graft, which typically means a long segment of good vein. Many people don't have that. And then finally, it needs what we call outflow. And that's where you would tie the distal or the furthest end of a graft into a vessel. And often there are not good target vessels to tie in. But on top of that, you're creating a new wound in an effort to heal a wound. And
Right.
if that bypass goes down, now you have two wounds instead of one
Right.
wound. So I still send many patients to bypass because it is still a good procedure, but it is a lot bigger procedure. So the interventions that I perform, the overwhelming majority of patients, far more than 95% of these, when we're complete, go home the very same day.
Mm-hmm.
So they're not even in the hospital one night.
Mm-hmm.
And I think that's very important because, it allows us to treat these. And secondly, peripheral vascular disease is often a disease that progresses. Well, by being an interventionist, it allows me to treat a patient a second time pretty easily.
Mm-hmm.
Once you've had a bypass, it's very difficult to do another bypass or a third bypass. And albeit I've seen patients who have had multiple bypasses, certainly that's more difficult and often it's fraught with more complications. So these new interventions are changing the way we can treat patients, and big advances have been made, better wires for crossing lesions. Once upon a time, we couldn't cross all lesions, and now it's rare to not cross a lesion. I've just started some research with a vibrating wire that seems to allow us to get through long calcified blockages and stay within channels. We'll see what happens as we do more cases, but at least encouraging results. Secondly, we got to the point of saying, well, the interventions weren't holding up so well. But now, once again, with drug-coated technologies, with some of the newer things coming out, results are more durable, stents, et cetera. And I think we're making headway there. New balloons, things like shockwave balloons or focal force balloons, once again, giving us the ability to treat people that historically we could not treat. I think these things have great promise, and I think they offer patients an opportunity that was not available before. But none of this can happen until healthcare practitioners understand the overall importance of peripheral artery disease, and they look for it. All too often, Terry, I'm getting a patient, once they already have gangrenous changes of the foot, or they've had a bypass and it's not healing, or a podiatrist may have cut a toe off or a toenail and it's not healing. We need to diagnose these things earlier. Just like you would never, ever wait for your car to start knocking before you change the oil, you should not do the same with your health care. And so this is as simple as someone checking for foot pulses. If the foot pulse is absent, there's peripheral artery disease. And we know now very clearly that is associated with higher rates of coronary disease or disease of the heart and of carotid disease of the vessels going to the brain. So I tell many of my young doctors that I'm training that sick legs are almost never attached to healthy people. And we can interrogate a whole patient by simply feeling for pulses in the foot. And if they're not present, we need to pay attention to that patient because that patient is at higher risk of death. That patient is at higher risk of heart attack. That patient is at higher risk of stroke. And of course, that patient down the road is higher risk of losing their legs. Now, that patient doesn't necessarily need to have a balloon angioplasty or a laser atherectomy or a stent, but that patient should start prevention. They must quit smoking. They must control their cholesterol. They must start walking programs. And all of these things can make for a healthier America. I like some of the recent announcements in the news that our FDA is going to focus more and more on prevention and healthy lifestyle. I think this is very important, and I think it's going to be one of the keys if we're going to achieve better health care in America.
And, I agree with all that wholeheartedly. And, just to step back for just 1 minute, one of the things, again, being a rep all those years, and I would be in the waiting room with the family members and, a patient that's undergoing an amputation, it's not just that patient, it's the entire family that gets impacted because of the, especially older patients that may not be able to rehab to the point where they can get a prosthetic limb. And now all of a sudden they're bound to a wheelchair. I
Yes.
mean, touch on that. I mean,
Yeah.
I saw it every day.
Well, Terry, that's why so many of these patients are sent straight from amputation to a nursing home, many of whom will never leave that nursing home because the families cannot even take care of them. And the cost, of course, of the nursing homes is tremendous. So, there are many estimates that the real costs of amputation way exceed $25 billion a year. And being able to avoid these, that's just direct costs. If you look at indirect costs, all the other things not covered by insurance, it ends up being a lot more. That is why early on, I did not just train cardiologists. I'm a cardiologist, and many people said, Craig, why aren't you just training our own specialty? And I said, because we're trying to stop amputation. So I trained vascular surgeons. I trained interventional radiologists. I trained cardiologists. I even trained some people that are called interventional nephrologists. And many of my peers said, why are you doing this? And I said, because it's the right thing to do. I don't think we have nearly enough people trained in our country today to address the tremendous problem that we face with critical limb ischemia, which has now been called by more chronic limb-threatening ischemia. We can and must do a better job. I think the award that we got is really vindication for me and a lifetime focus on this huge problem. I still do a lot of work in the heart. I still work a lot in the venous system. But I must say that patients who have severe peripheral artery disease are often prisoners in their own bodies. They can't do what they would like to. They can't walk to the store. They can't walk to the mailbox. And then, of course, later on, they can't walk at all, perhaps when they lose their limbs. And being able to help these people is important. And I'm quite certain it has resulted in saving lives. And I cannot mention enough how many of these people, in finding the blocked leg arteries, it was their only clue that later on led us to find out that they had critical blockages within the arteries to their heart and up to their brain. And they just could never walk far enough to feel chest discomfort or anything. So this is, I think, a major focus that all healthcare practitioners have to look at.
Well, I totally agree. And again, I got to congratulate you on this wonderful award, but also the efforts of Kim McNicholas and her group, The Way to My Heart Incorporated. She's done a wonderful job to basically shine a light on these great practices out here that are focused on critical limb ischemia. And, Dr. Walker, thanks for, again, giving us more information and helping all of us understand. And, if you're out there and you're watching this and you have questions or you have a loved one that needs some help, I mean, you can find Dr. Walker's group very easily at www.cardio.com. And they've got a ton of locations, and they're easy to get to and easy to get in front of. So I would highly recommend that. If you don't have someone in your area that can provide these kind of services, look them up because it's worth traveling to. So thanks again, and next week we'll be talking about important advancement in the treatment of hypertension. Thanks, everyone.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.